Good morning, everybody. So today we're going to talk about Medicaid, the other major federal program initiated in 19. Uh, and it was at the time linked with welfare, which at the time welfare was called AFDC and administered at the state level with federal money subsidizing the states to provide some living assistance for the poorest people in the country. And AFDC later got converted during the Bill Clinton administration. The benefit was limited to, I think, at most 5 years. You couldn't spend more than 5 years of your life receiving welfare assistance from the government. And I think one of the things to especially understand is that in the United States, receiving welfare has always been stigmatized. If you are poor, you are somehow a bad person, inadequate person, a loser. And I think in this country more than in most, it's acceptable. The acquisition of great wealth somehow means you're more of a person than you otherwise would be. Even the election of Donald Trump, I think in most countries, it's not that they might not elect somebody who's very wealthy. I just think it's a little more likely in the United States. Wealth being associated with you're somehow a really good person. You're smarter than everybody. So so this decision was made to say that, well, if you're poor enough to qualify for welfare, then you're probably going to need help with medical care as well. So, and then and sort of the system was already in place in the states across the country to make this decision about who gets Medicaid. No, I mean, who gets welfare, in other words, who's poor enough. So that same decision-making process could be used to figure out who gets this aid for accessing the healthcare system. So anyway, that was what was done, and we're going to learn more about some of the implications. And I should have slides. Wish I could see them better, but I can't. But anyway, this is the right one. Um, been trying to put this on slideshow, but there's a whole different set of commands and I'm not seeing it. Anybody know where that might be? Oh, maybe there. How about that?
Are you trying to make it full screen?
Yeah, kind of was.
Yeah, and if you press from beginning.
Yeah, hold on. Got it. Okay. The downside here is I don't have my cell phone, so I'm not going to know what time it is. But anyway, let's just go ahead. You can stop me if it's running over. Okay, so Medicaid's a state-run program run by the state governments with substantial federal matching funds. And the states have a good deal of latitude, which I'm going to highlight later. They can modify which populations are going to be included in the program, and especially how poor do you have to be to get this aid. And however, there are some populations that are mandatory and determined by federal rules that the states must obey to get this money. So here are some major dates in the history of Medicaid. It was founded in 1965 as a Great Society program. But it's very important for you to understand as you go across the country and maybe work in a state you were brought up in, to understand that the states give it other names. Every state can name it whatever they want to. California, it's called Medi-Cal, but that's their Medicaid program. So Colorado, Health First Colorado, Iowa Health Link, TennCare in Tennessee, and the children's portion of the program is called Dr. Dinosaur in Vermont. And I just want to say that decision to call it Dr. Dinosaur is made very intentionally to have mothers and mothers and little kids at the time, this was 25 or 30 years ago, to wanna, oh, you're gonna be in Dr. Dinosaur, we're enrolling you. It made it sound more kidsy, and stuff that kids would want. So that was kind of the thinking. Then during the Clinton administration in 1997, the CHIP program began, Child Health Insurance Program, and that doubled the number of eligible kids, raising the eligibility. So currently 37 million kids have coverage through Medicaid. And just to make this statistic easy to remember, on the one hand, 48% of all kids in the US are insured through Medicaid. So when you're cutting Medicaid, that means that just about half the people in this program you're cutting are kids. So you're going to cut Medicaid, keep that in your head and in your moral code. Conversely, kids comprise 47% of all Medicaid beneficiaries. So this is not widely known, but it's a heavily pediatric program. And in terms of distinguishing Medicaid from CHIP, it's basically the same thing. And it became even more so in 2014 when Obamacare happened. And basically, Obamacare did for adults sort of what CHIP did for kids, but to a lesser extent. In other words, the Medicaid expansion during Obamacare in 2014 added very poor adults, even those who didn't have children, to up to 138% of poverty that became a benefit that the states could get a whole lot of federal money to provide. So in other words, and I just want to say the Medicaid mentality of those founding the Medicaid program was that the parents of young children in poor families were a more sympathetic group to provide coverage to than than very poor adults who didn't have children. They were like, less worthy somehow. And in a lot of states would provide Medicaid coverage to very poor adults who were raising children, but deny it to people who didn't have kids. Interestingly, that's kind of going on now in the Trump administration. Some of the programs that are designing that they would not help people who don't have children, that they're somehow bad people. It's very interesting. Anyway, Obamacare expansion was as the Obamacare legislation was fought tooth and nail all the way by the entire Republican Party, taking it all the way to the Supreme Court. And the Supreme Court ruled that the exchange subsidies were all going to be legal to get coverage for many adults and many families, actually. But the Medicaid expansion for the even poorer people was going to become something the states could opt out of. It became optional for the states whether they were going to implement it. Within the legislation, uh, there was a big financial incentive for the states to adopt it. And many health policy experts were kind of shocked by the fact that many of the states were refusing to do it. And it became extremely partisan. I mean, all the blue states immediately adopted it the first day they could to allow 20 million, these 20 million people whose income were between, 100% of poverty and 138, 138% of poverty would be able to get coverage. And I don't think I've written it elsewhere, but you might have, I guess you're going to hear more about Obamacare today, probably late with Ken, Dr. Dolkar. But basically, for the first few years, the federal government would literally pay for the whole thing for this expansion population, and thereafter pay 90%. So it was a huge incentive for the states to do it because they were having to kick in so little, but they nonetheless refused. And the mentality of that politics is hard for me to explain because I'm not sure I can grasp it. Anyway, in January of 2025, 78.5 million Americans were enrolled in Medicaid or CHIP, comprising 23% of the US population. So that's the month that Donald Trump's current administration began. And at the time I'm giving this talk, we don't yet know if the effort in Congress that the president says he will sign to drastically cut Medicaid will be happening. But that's where we're kind of starting with 78.5 million Americans and just under half the kids in the country enrolled in Medicaid. What will come of it all at this point, we don't know. So the mandatory eligibility the states are requiring to do is it's only available to legal residents, and eligibility is tied to income, wealth. If you own a mansion, you're not going to qualify. If you're permanently disabled or even temporarily, it's kind of complicated, but you're more likely to qualify. And in the states have to obey this law, and then there's other optional parts of it that they will end up implementing and figuring out who qualifies. But there's certain basic elements of wealth and income and disability that are required, and then states can be more generous and then come up with their regulation that their bureaucratic establishment will implement. So the benefit package is very comprehensive. First day of the internship, we talked about that there's two ways to be comprehensive. One is to have a broad benefit package, everything, doctor care, hospital care, substance abuse, the whole deal. And the other way is to not require co-payments, cost sharing. And Medicaid does both. There have been efforts to make patients pay just a few dollars, but that's the most that's have been required. So once you got Medicaid, theoretically, you have great insurance that's covering everything. How good that turns out to be, there's other factors that are going to play into that. Can anyone think of some other factors? Whether patients are empowered to access care. Anything come to mind?
Reimbursement rate, which hospitals will accept it or
Can you
provide
just
it.
speak a little louder, or maybe I
Oh,
should.
so,
Sorry.
the reimbursement rates and subsequently which providers or hospitals will accept your insurance if it's through Medicaid.
Yeah, it's exactly right. The neither a hospital, unlike Medicare, well, it's not even true. I was going to say that Medicare hospitals have to take Medicare, but they don't. Hospitals can refuse to take both. And your point that the reimbursement rate may become an issue is a huge issue. And so there are hospitals that refuse Medicaid or will try to find ways to avoid taking care of Medicaid patients for that exact reason, that the reimbursement rates are poor. More on that later. Medicaid programs also can provide some social supports, and some of those are required for disabled, poor Medicaid recipients. They can get a transportation benefit to get to, not everything, but just to get to medical appointments. And then for children, dental care is required as a mandatory benefit. But you got the same issue we just heard about, is will the dentist be paid enough to actually accept Medicaid? And that answer is far less rosy than in general than even for doctors. So then there's the optional features. States can opt out of providing them or set stringent eligibility criteria. So because of the Supreme Court ruling on Obamacare, Some of the states accepted the expansion and are covering childless adults up to 138% of poverty level. Dental for adults is an optional benefit. Eligibility for kids can be taken, is allowably to be taken up to 380% of the federal poverty level. Now, I want everyone to understand, if you have a kid who's at 300 in a family with 381% of federal poverty level, I want you to understand what you're losing. Have I made it clear so far? Maybe I'll just go through it. So the idea is that there's a federal match. They're given the state a certain amount of money to provide care. So if it were a child at 381% of poverty, then they could not receive any federal money for that child. But if the kid's at 380% of poverty, then they can take advantage of matching federal funds, put that kid into their Medicaid program. So eligibility for kids and parents for the child's first year of life varies up to 138% of federal poverty level. And 40 out of 50 states are shoving Medicaid patients into managed care. Now, we also said that 40 out of 50 states accepted the Medicaid expansion. But in this case, those aren't the same states. It's sort of random. Like New York, I think, has shoved patients into Medicaid patients into managed care. But my side of the border in Vermont, they did not. We're one of the 10 states that did not shove Medicaid patients into managed care. More on that later. So let's just compare two states. This slide I made last year, and it's because we had a student who was very interested in healthcare in Mississippi, her state of origin. So just to look at this, some of the stuff on this graph, we're going to look at in a little more detail. So let's look at the top row from Vermont on the left and Mississippi on the right. So in Vermont, 187,800 people are enrolled in our Medicaid program here, which is 26%, I'm sorry, which is the one in the middle, 23% of Vermont's population is covered by Medicaid or CHIP. On the same graph on the Mississippi side, almost identical percentage of the Mississippi population, 24%, is covered by Medicaid in Mississippi. But these two states are very different. In the left upper corner, that pie chart shows that only 28% of Vermont's population is low income, which is kind of average for the country as a whole. Whereas Mississippi is a very poor state. It's, I think, along with Arkansas, the poorest states in the country. Louisiana might come in third, along with Oklahoma and New Mexico. Anyway, so those are really poor states. And 41% of Mississippi's population is low income, a much larger percentage than in Vermont, but yet we have an identical percentage pretty much enrolled in our Medicaid programs. So what's going on here is that philosophically, the government in Vermont, year after year, regards providing coverage to as many people as possible as a very high priority and have been willing to raise taxes to do it. And in Mississippi, the drive to not raise taxes apparently is more of a social value to those who govern the state. So they have ducked providing coverage to additional people, Mississippians, even when they could get substantial federal money and would have to put in relatively little themselves, like in the Medicaid expansion. So they've ended up with a lot of fairly poor, very poor people who don't have Medicaid coverage. And the going to those people graphs on the lower left, in Vermont, Medicaid covers 2 in 9 adults age 19 to 64. And those people graphs on the right, 1 in 7 of Mississippi's adults age 19 to 64 are covered in their Medicaid program, even though their demographic, their adult demographic has a much higher percentage of very poor than Vermont does. And however, when it comes to children, Vermont only covers 44 in 9 children, 44%, whereas Mississippi covers 1 in 2 children. And it's not because they're generous, it's because the programs, the Medicaid and CHIP programs are mandatory. And there's so many poor children in Mississippi that they've ended up with one of the highest percentages in the country at 50% of their children being covered. And this same thing happens with nursing home residents, that elderly people in Vermont are much overall wealthier. They're wealthier than Mississippi's nursing home residents. So a very high proportion, 75% of nursing home residents in Mississippi are covered. And then similar thing for Medicare beneficiaries in general, that Vermont's elderly population is more affluent than compared to Mississippi by a long stretch. So, and then for people with disabilities, it's a more similar percentage. Vermont has done everything they can to get more people coverage. And then I want to draw your attention to the pie chart on the bottom right in this slide. So 73% of adults on Medicaid in Vermont are working. Whereas in Mississippi, it's so hard to get Medicaid that if you're working, you're almost guaranteed to not qualify for Medicaid because their cutoff criteria is so low. So this is something we're going to come back to later. That in Vermont, the disincentive to work in order to get Medicaid coverage is not what it is in Mississippi, where it's very strong. If you need Medicaid coverage and you live in Mississippi and a job's available that's going to get you a few bucks to supplement your family income, you're probably going to lose Medicaid in Mississippi. Whereas in Vermont, you'll more likely to be able to hold on to your coverage if you don't earn too much. So what we're talking about here is a disincentive to work by having incredibly stingy eligibility requirements for Medicaid. You can go to work in Mississippi, but then if you need health care, what are you going to do? You probably have trouble paying for it. So here's more, just the federal share of match. Okay, so this is an important issue, is how much money the state has to kick in to expand, to have a more generous rather than less generous program. In Vermont, we're wealthier than Mississippi. So for every dollar we spend on Medicaid, 55 cents come from the federal government and 45 cents come from our taxpayers here in Vermont. So federal share is 55%. Mississippi on the right side, the Mississippi graph, what it's showing is that in the upper left-hand corner is that most of Mississippi's population, when Mississippi expands their Medicaid program, I'm sorry, let me say it differently. When Mississippi's spending money on Medicaid, for every dollar they want to spend more on Medicaid, the federal government's going to pay 78%. That's the highest match there is, leaving aside the Obamacare part of it. So in other words, for the mandatory population, in other words, the non-Obamacare expansion, the federal government is going to give somewhere ranging from 50 cents in the richest state to 78 cents in the poorest states, which Mississippi is. So the poor states are getting more to make their Medicaid program less stingy, but Mississippi didn't do it anyway. And they not only are they've kept all the optional things as minimal as possible. And on the upper right is the Obamacare share, which is the federal government paying 90%. And Mississippi refused that as well, which this graph doesn't make clear, but anyway, that's the truth. So once again, on the middle pie chart, 40% of births in Vermont were covered by Medicaid, whereas it's 60% in Mississippi, and that's just because people are so poor. Anyway, so I'll stop there in this comparison, but these two slides are giving you a sense of the latitude that states have to try to get more of their populations covered with matching federal money. So this gives you a sense of the portion of their population covered by Medicaid. And in general, there's kind of two types of states here. Look at the black states in the upper part of the graph, New York and Vermont, and then California. Those three states are not especially poor, particularly Vermont, but they've been willing to spend as much taxpayer money as they've needed to with the benefit of a federal match. So that again, in Vermont, we spend, for every 45 cents we send, we can give $1 of benefits to our patients. So we like that. So we're going to spend more because we want more of our population covered. So those states that are in black, it's because their government has viewed providing coverage more broadly as a priority. But whereas some of the states that are not black are actually very poor, Mississippi being the best example, and Alabama's got a lot of poor people, so does Tennessee. On the other hand, there's a couple red states, Arkansas and Louisiana, that are very poor, and their government has not been quite so stingy. I think that both states ultimately, took the Medicaid expansion, but you could correct me. I could be wrong about Arkansas, but I think they did. And so there's a slightly different philosophy in those states. Texas has huge numbers of poor people, but they would not opt into it either. So they should theoretically be in black. They should have a higher percentage of their population covered. On the other hand, a lot of the northern states, like especially Idaho, they're a relatively wealthy state, and they have been willing to participate in, although reluctantly. I think it took them a long time to accept the Medicaid expansion. So this is giving you a sense, these last few slides have given you a sense of the power that state governments have to use this matching federal money in the Medicaid program to get coverage for their populations. And again, this graph just shows where the poverty is, and we've already kind of discussed this. So Medicaid financing. Medicaid is jointly funded by states and the federal government, but administered at the state level. And the federal government matches state spending for enrollees and for qualifying services. And the formula of a federal share of traditional Medicaid, somehow I can't see this, varies by state based on poverty level, as we already saw. So again, the states that are poor have a higher federal match. And these wealthy states like California, New York, are not getting such a great match. They're at 50%. And Vermont is in a sense the most extreme example, because we're not a wealthy state. We don't have the rich people that Connecticut and Westchester County, New York have, bringing tremendous wealth potentially into their tax coffers. We don't have that, but it's our government has been generous in terms of trying to get as many of our population covered as possible. So it's just different in philosophy up here. Medicaid eligibility level for kids is expressed as a percent of poverty. So again, the black states, you have to be, we're covering people here up to 380% of poverty, every single kid that we can possibly get covered. And interestingly, Wisconsin is not known as a liberal state. It's a sort of a 50-50 state, but they have had enough dominance of the desire to get their kids covered that they've been a fairly generous state. And the same for Iowa. Iowa politically is a complicated state, and they've wanted to be generous with their kids. I think there's more a big sense of social solidarity in the upper Midwestern part of the country in general that's changed. But there's historically that's been there for a variety of reasons. So here's the overall Medicaid enrollment, now up to 78.5 million. So here we're getting to reimbursement here, and across the country, ranging from Vermont to Mississippi, Louisiana, reimbursement is bad. Very low reimbursements, ranging from low to very low. Physicians in hospitals generally lose money for many diagnoses when they treat patients insured this way through Medicaid. And this knowledge, now, when somebody comes into for my treatment to my clinic or something, or the clinic where I work, and I see that they're covered by Blue Cross, I really don't know how good the reimbursement is. I assume it's better, relatively good, but I don't really know how much. Whereas when it comes to Medicaid, every nurse and doctor knows that we're not getting much money, that this is semi-charity to provide care for this population. Everyone knows that these are poor people that we're treating. And as such, depending on their personal philosophy, you will hear expressed in very pejorative terms, you'll hear nurses and doctors say, "Oh yeah, she's a Medicaid patient." And that statement, "she's a Medicaid patient," means less worthwhile. Well, I don't know how else to say it. Less worthwhile human being, maybe kind of parasitic, and in some cases, not that often, fortunately, they'll actually treat them differently. And since most of the minority populations of color in the US are poorer by a stretch than the white population, this plays into racism. If you see, say, a black woman with a child walk into the ER, just at the moment they're walking in, there are many healthcare workers who will say, "Oh yeah, that's probably another Medicaid mom who, is overusing the healthcare system." So this is something you will see, and I encourage you to think in advance how you want to respond to that. And because it's really hard to say to someone who says that, that's kind of disgusting, and I don't agree with it. It's distasteful to me to hear that the person's gonna look at you like, who are you to be holier than thou? So this is something you'll have to think about, and we can talk later maybe about how you would approach that kind of statement. So we're going to talk later about the fact that many states have been subcontracting out their Medicaid programs to private companies, but it really hasn't had much impact on the pejorative behavior. So on the big groups that are in Medicaid, there's low-income families, especially if there's kids involved or pregnant women. And then individuals with disabilities. So kids with autism and long permanent disabilities, cerebral palsy, HIV, serious mental illness, they'll get covered. So, for example, in the mental health world, there is a population of people who are suffering with an illness called schizophrenia, otherwise known as psychosis, and the majority of this population are unable to work, and their illness is hard to treat. The drugs that treat it are pretty side effecty. They're kind of difficult drugs that can sedate people to some extent. So, many individuals with that diagnosis and some others with chronic mental health conditions are covered through the Medicaid program. And I don't think our internship is going to get into this, but the mental health system is very kind of polarized into the group I just talked about, and generally wealthy people who have enough money to access counseling if they're going through a life stress or depressed or anxious, that they'll access a private system. And very often the same doctors, it's a completely different set of doctors working in with those two populations. Very, very polarized, much more so than for physical health care. So then the third group are the elderly, and there's a somewhat more generous way to get Medicaid coverage for the elderly. And among the nursing home population of the country, they're overwhelmingly elderly, and many of those people qualify for Medicaid. And in fact, 60% of nursing home residents in the country are covered through Medicaid, which doesn't pay the nursing home real well, but it's better than nothing. So most nursing homes will not throw out people insured through the Medicaid program, but instead try to organize their services inexpensively enough to allow them to want to have the bed filled rather than empty. So again, health insurance coverage for 23% of Americans. 10 million of them have Medicare and Medicaid coverage at the same time. These people are generally pretty sick with major illnesses and could be elderly, obviously, but they also may have long-term disabilities and be very poor. Because remember, Medicare, you get into Medicare if you've had what looks like a permanent disability for 2 years or more. And then it's 60% of long-term care financing. And it's an important support for the healthcare system and the safety net. And I just want to say that support for the healthcare system is really going to come up if the Trump administration and the Congress really implement this piece of legislation that's drastically cutting Medicaid. Because a whole lot of providers are not going to get paid. And even if the reimbursement is not great, it's not zero. So the whole safety net of this country, public hospitals especially, and rural hospitals, they're going to be creamed if this legislation passes, because many of them are already barely hanging on. And the states are more able to address COVID pandemic and other challenges because of Medicaid. So let me just go on here. So almost all states have balanced budget requirements. Unlike the federal government, where we just throw it on the deficit, the states can't do that. And even the only state who doesn't is Vermont, and we basically have to balance our budget because our credit rating got downgraded a little one time in the last 20 years, and everybody did not like that because it meant we're paying higher interest on all our bond, all our highway construction bonds that we were working on. So basically states have to balance their budget, and that has meant poor reimbursement to providers, because that's the one thing the state can do, other than just cutting people out of the program, which in Vermont we have not wanted to do. So Medicaid is counter-cyclical for the economic cycle. So sometimes the stock market crashes and the economy and there's mass unemployment, like there was in 2008, 9, 10, 11. And what happens during recessions is that the state government's getting less tax revenue because the economy's crashed and more people are not working, and more people qualify for welfare and Medicaid at the exact time the state has less revenue, and they have to balance their budget. So this is a real problem, and I'm not saying I have a great solution other than creating a rainy day fund. So, the typical response, if they don't have a rainy day fund they're willing to use, is to cut reimbursements. So 70% of physicians accept new Medicaid patients, meaning 30% don't. And this graph showing the states that are more likely to, this is no longer the state government. So in other words, the less generous state governments like Mississippi, still they have a relatively higher percentage of physicians accepting new Medicaid patients. And notice the entire underpopulated regions of the country in the upper Midwest, all those states, most of their doctors take Medicaid. Anybody want to speculate on why that is? Compared to New York State, it's supposed to be some liberal state, but we have one of the lowest percentages of our doctors accepting patients with Medicaid coverage.
Are there more? Oh, sorry.
No, you got it. You got it.
Something's wrong with my sound. I should try to fix that, but I can't right now. So please speak up.
Are there more like for-profit hospitals in those states?
Well, Tennessee certainly has them. Florida has a lot of for-profit hospitals, but I don't know how much of an explanatory factor that is. I don't know that answer. I'm sorry. Because here you have Texas and Louisiana contrasted. Yeah, I'm sorry, I don't know the importance of for-profit hospitals. I would guess, okay, let me give a different answer to your question. Yes, for-profit hospitals are less likely to accept Medicaid patients, but they do accept some. I don't think there's any that really flat out refuse them at this point. Go think more about doctors rather than hospitals in answering this question. Or, well, anyway, yeah, think about doctors. How about if I throw in urban versus rural and look at it again, this map? So what are you seeing here? Think about the states that are the most heavily urbanized. So what do you think's going on here?
Do the doctors in urban centers have a significant enough private insurance population that they can just refuse to treat Medicare or Medicaid patients because they have enough
That's true. If
revenue?
they're out in a
Oh,
suburb, a wealthy suburb, and everybody's wealthy, they can fill up their practice just with those people. So that's the positive part of it. But when they're trying to sleep at night and thinking about whether they should feel guilty, what is it they know when you're in a city? or they hope at least. What are they thinking is gonna happen to those patients insured through Medicaid?
Are there more community health centers and free clinics in urban?
Absolutely. Yeah. There's going to be community health centers. They'll somehow take care of these people. And so I can treat all the rich people and make a lot of money and just go to bed and sleep well. Exactly. It's exactly right. So, these states, South Dakota is not a liberal state, but when you're in a doctor's office in some little town in the middle of South Dakota, you're going to treat everybody. And the rural hospitals are going to do the same thing. They're going to take everybody who lives there. That's their mission. They've always done that. Again, a lot of hospitals in the country were founded in, 1920s and then a bunch in the late 1940s. And, they've always served their population. It would be a big change for them to say, we're not going to do that anymore. So this is an urban versus rural map. That's really true for primary care and basic hospital services. For specialty care, it's a little more of an issue. A lot of specialists will take Medicaid patients. In other words, I think if you looked at the data, that 70% figure, I think it would be worse for primary care. It might be 60 or 50% for primary care, but higher for specialists. This is because a specialist in a small or city, say in a small city, that specialist, there may only be 2 nephrologists. So they can't really say no to all the primary care doctors that need a consult when they're, as they're taking care of a very poor patient. The specialists in a smaller place may kind of feel more obliged to just take their share of Medicaid, of patients insured through Medicaid. And I think the other thing in Vermont, all the hospitals, all 14 of our hospitals accept Medicaid patients. And I think there's an assumption that so a lot of people in Vermont live near one of the hospitals. They're completely perfectly distributed geographically. They're scattered as they should be, exactly the way you would want if you were, a health planner looking at Vermont. Where should the hospitals go? They're all exactly where that you would want them. So there are patients who live halfway between, one hospital area and the next. But in Vermont, at the hospitals, there's this kind of tacit agreement that we're not going to refuse Medicaid patients. We're going to take them. And so, from the border areas, we're just going to take them. We're not going to be nasty about that. And it's just an ethic. And, in other places that may not be the case as much. So, it's sort of an ethical thing. And I think in rural areas, it's just kind of a tradition to take care of everybody in your little community. So many specialists, however, won't see kids with Medicaid, and psychiatry is the worst. Orthopedics is pretty bad, and that's because they're the highest paid and they've intentionally have a shortage of residency slots. So there's been a shortage of orthopedists throughout the country, more than most specialties. But, so it can be difficult getting patients in to see specialists, but usually one way or another, you can get patients in. But, this theory I have about specialists, it may not be especially true anymore. And it would be interesting to actually research that and see. It's possible that specialists aren't really doing that much better than primary care anymore. So, anyway, um, what you're seeing here is that children may have trouble getting into specialists, whereas almost every specialist accepts private insurance. Note that the mental health field, psychiatry, there is an exception, that many health insurance companies have not have placed obstacles in the way of accessing mental health care. It's been discriminated against. Mental health has been discriminated against by insurance companies. So many psychiatrists won't take any insurance, neither Medicaid nor private insurance, and the patients are paying out of pocket for their therapy sessions. But all the other specialties, you know, it will be. Everybody would take private, and patients with private insurance coverage. So Medicaid, despite all the issues we've been talking about, the stigma, the fact that it's maybe harder to find a doctor, especially in a city, who takes Medicaid, still, it's better than being uninsured. And the odds ratio for having a doctor visit, if you're covered through Medicaid versus going bare and having no insurance, you're 5 times more likely to see a doctor, 80% more likely to know that you have hypertension, and 70% more likely to have it well controlled compared to having no insurance at all. So it's helpful. Randomized controlled trial in Oregon to provide Medicaid versus no Medicaid. It's a study that's rarely done because it's randomized trial assigned by randomly. So it's a high quality study. And they took people in the elective optional part of their state program as they were working on expansion. In the first year, instead of bringing everybody into the Medicaid program that was optional for the state to cover, they did a trial and they wanted to see if their program was actually working. And they discovered that you were twice as likely to get a mammogram, more likely to have a pap smear. Your depression was more likely to be treated, so you're doing better. Your diabetics were more likely to be taking meds. And people overwhelmed by catastrophic medical costs, you're 5.5 times less likely to face catastrophic medical costs if for the people that they randomly assign Medicaid coverage to. So another trial showing that Medicaid really helps. Some of the Republican Party proposals all along, this slide predates Trump, attempts to impose copays, impose work requirements, work on excluding anybody who could conceivably not be legal immigrant, push for block grant funding. By the way, you can't get Medicaid if you're actively trying to immigrate to this country. You have to not require it. But there's more complicated regulations once you're in the country for a while. And then a push for block grant funding. In other words, instead of giving us here in Vermont, say 55 cents for every dollar we spend on Medicaid, the government could just say, last year you got, say $1 million from us for your Medicaid population. We're just going to give you $1.05 million next year, and we don't care how many people you include. You can pick up half your population. We're not giving you more. So they like the idea of a block grant. It's as a strategy, kind of reduce funding, really. So managed care began in the mid-1990s, got contracted out, and by 2017, 40 states, 2/3 of all Medicaid recipients were covered that way. Gives them budgetary predictability to just say this, we're subcontracted, this is how much we're paying. They hope to save money. The rhetoric was that managed care would improve care coordination, which is just a fantasy. There's just no evidence for it. But that was the fantasy, and that was the rhetoric. And they would enable more flexible benefits. In other words, they could avoid providing services that the private insurer didn't think were beneficial. They could network management means cut off some of the doctors so they weren't included in the panel. And then payment schemes where they pay the doctor, less. Like I was in one of those schemes once involuntarily, and the more x-rays and specialty visits my patients got, the less money we were getting. So they were literally penalizing us for referring people who needed specialty care. This is what goes on here in the US. So 40 states involved, and 11 states, DC don't. And then a few states have more complicated programs. Oregon has a more interesting program where they actually do it through doctors rather than insurance companies. So that's sort of been much more benign. But anyway, and you can try to implement more intensive primary care offerings. And I'm not going to get into those because we don't have time. Then in a few states, They got rid of the managed care organization. That was Connecticut and Oklahoma, and both states saved money. They did an audit and finally realized that, yeah, we're really losing money on this managed care insurance company privatization scheme, so we're going to get rid of it. And then Oregon is a more complicated, innovative program, which I won't get into. Medicaid managed care for the insurance companies themselves, very profitable. So over $1 billion in 2013, went up all the way to nearly $4 billion in 2015 as the program expanded due to Obamacare, all these extra people covered in Medicaid. And, the profitability went up. And as I mentioned yesterday, that the sickest people who are in this special group of dual eligibles and chronically disabled people, they're much easier to make money from for when that's privatized, because you can just deny services. And these chronically disabled people often have major illnesses that cognitively could not write a letter complaining when they're not allowed to see a doctor. It's not within their capacity as part of their chronic illness. So so $90 per member on dual eligibles is their profitability, whereas it's only $7 for younger people who might be in more of a position to complain, and they need less care also. So you can really profiteer off the sickest people, and they do. The accounting has been very muddy. There's not been openness to understand what in God's name these. In general, this is the sleaziest sector of managed care and health insurance in general. The refusal rate of denying services, they require a lot of prior authorization, and the denial rates in many of these companies as much as 25%, and that is not uncommon. So you can imagine what that does to doctors trying to treat these patients. Very little accountability. And then there's a lot of variation in how the insurance companies do in terms of profitability. But that last one about administrative costs for state Medicaid programs, it didn't get reduced that much because the states have to spend money being a sheriff and making sure that their patients are actually getting care. So it's not much of a deal, but ideologically, privatization has been in vogue for these, the whole Reagan era. So it's still happening. So in Hawaii, they converted fee-for-service Medicaid to managed care in 2 steps. It increased the administrative burden on doctors. Many doctors dropped out. There was worsening access. Cost increases were actually greater than the US average by 3%, and it was especially bad for people with mental illness. So managed care enrollment has been growing. And it's a major revenue source for insurers. A lot of money being made. And states have done a lot to control drug costs, taking drugs off. So I don't think these obesity drugs are covered. And again, a lot of the enrollees are in these plans. And if you do require managed care enrollment, you can leave it voluntary, and if so, there should be at least 2 plans available, but that's not even widely obeyed. So penetration was up to 82% by 2018. And there's capitated managed care models to deliver services in a lot of states. This is a variant of all the anyway, so here's Medicare managed care. And what you find is that when you're a primary care doctor trying to refer your patient for a specialty visit, you have a good chance of the patient. You try to make a referral to a doctor on the list in their network, and they aren't participating, nearly half. Or they won't take a new patient who's in that plan. Or a lot of them, the appointment, will be delayed. and the percentage that got an appointment in less than 2 weeks turned out to only be 25%. Note who did this study at the bottom. This is the Inspector General of the United States serving as a theoretical patient. So this is a real study that is viable. So anyway, that's what I have.